Welcome to episode 7 of The Other Side of Lucy Letby, and we're going to carry on looking at the evidence given by the chief prosecution witness, Dewi Evans. So Dewi has already ruled out everything. He's ruled out every possibility of death without telling us how, apart from our embolism, and he hasn't told us why, apart from the presence of a rash, the famous pink rash, which no one wrote down. Apart from that, he hasn't given us any other substantive evidence. So his reasoning goes, baby A collapsed. Dr. Jairam said he's seen a pink rash. Therefore, baby A died because of our embolism. We've already heard that Professor Owen Arthurs, the radiologist, claims that finding post-mortem error using a portable X-ray is sufficient to talk about route of entry of the error, and that's simply not true. And later on we'll get to an independent pathologist who claims to have seen globules. I don't even know what that means, but these globules are supposed to be proof of our embolism as well, and they're not proof of our embolism. I told you in episode 5 that the method of Perucci and Gershon is the only method that by which we agree that our embolism is present. So that's the scientific standard. So what evidence did Dewi have, or how was he able to rule out sepsis and hypovolemia, which is the lack of fluids that he says, the medical term would be hypovolemia, or hypoxia, which is low oxygen in the system. Now, I said the baby had all three. And the reason I said the baby had all three was because the clinician said that the baby had sepsis, that the baby, by my reckoning, has no fluid for a minimum of 4 hours, but probably longer than that, because, again, the drip went in, the umbilical venous catheter went in at 1, but no fluids ran for 7 hours. And I think the problem for Dewi Evans, and the credibility of his evidence, is that we seem to be missing substantial piece of information on baby A, and that is blood tests that would show us what a thing called the anion gap is. The pH is a continuation of the elevation or otherwise of the lactates, serum, sodium and potassium, and all of these things that are really critical and are usually controlled by fluid management. Here in this situation, we don't have what you should call fluid management. So how quickly can hypovolemia or blood volume depletion affect a preterm neonate? Very, very quickly. And the reason for that is that the baby comes into the world with simply the stores that the mother gives it. When it's preterm neonate, those stores are very deficient. The baby loses a huge amount of water through what's called insensible water loss. And that's really critical, that you have to usually nurse these babies in plastic bags and that type of thing at the early stage of the resuscitation. It has to be very detailed and focused, and the drips have to go in and they have to stay in. So this is disastrous management of the baby right from birth. And then we're going to leave it effectively 24 hours after the baby's born. We get round to putting glucose into the baby. Now, we don't know what went through the little peripheral line, not the central line, but the little peripheral line that tissued, to use a very bad term, earlier on in the day. We don't know if there was glucose in that or how long it ran for or anything like that from the evidence we have. There's certainly in the record given in court not enough evidence to say that this baby's fluids were really well managed, and that should have been a subject of discussion when it clearly was not. So the anion gap is an important clinical calculation to help diagnose and differentiate types of metabolic acidosis in neonates. So the anion gap is calculated by subtracting the serum concentrations of measured anions, which are chloride and bicarbonate, from the measured sodium, which is a cation. And that gives you the anion gap, so the difference between positive and negatively charged ions. So it basically helps identify conditions like lactic acidosis which occur due to poor tissue perfusion, hypoxia, or inborn errors of metabolism. That's like genetic or otherwise inability of the baby to create energy. So if we look at all three things together, like the anion gap, the lactate levels, and the pH, they can be indicators of mortality risk in preterm neonates, really. So they can be indicators of mortality risk in preterm neonates. The evidence is stronger for some measurements than in others, so you'd really have to pay attention to all of them. So the purpose of this really is to show you how technical that neonatal care can be. If you have to be getting into these very nitty-gritty things, pH, the acidity of the blood, and the anion gap, and the amount of chloride, and the amount of sodium, and etc., you have to know all that real detail, and you have to kind of know it on an ongoing basis. And as we can see, that's clearly not the case here. And these things really do matter. And if a neonatologist was there, this is the type of information that they shouldn't have been given to the jury. Without this information, I don't think Dr. Evans can reach a conclusion that the baby wasn't affected by loss of fluids or imbalance of fluids or acidity or lactates. He's not able to say it because he doesn't want to go near that. And there could be a problem with antibiotic dosing here as well, because we have a diagnosis of sepsis, whether Evans likes it or not. We're less than 24 hours of life. If we don't know whether any blood cultures were sent, we don't know if a lumbar puncture was done, etc. So Evans cannot say that there's no sepsis here, and sepsis will not necessarily show at a post-mortem. And that's important to know too. So we don't know, but he can write it off. But as I say, we have a problem with the antibiotics, because antibiotics were given, but then there's a delay, and they're not given again. That I can see. Now, perhaps they were given and it just wasn't discussed in court, but it should have been discussed in court, along with the usual methods of care that are usually carried out for preterm neonates in special care units. They're all missing here, and I have a serious problem with that. So the prosecution just carries on here with the usual stuff, and no point in going over it again. So we'll move to the cross-examination from Mr. Myers and see, do we get any further to the truth with that? Ben Myers, defendant, asked Dr. Evans, has he prepared a large number of reports over the years, and bowel embolisms feature in a number of them? And Evans says literally dozens. So this is really interesting. So Evans is saying to Myers that he's written many reports, a large number of reports over the years that include features of bowel embolism. Yet he's only seen one in clinical practice. That is very unusual, I think. It would be really interesting from a purely academic point of view to find out what other cases Dr. Evans had written reports for that included the diagnosis of bowel embolism. You know, just for fun, and let's see how he reached the conclusion in those cases, and was it any different than how he reached the conclusion in this case. And then he says something very extraordinary. He says, this occurs when there are no other explanations which fit the collapse, and when resuscitation is unsuccessful. But we know that there is at least one other condition that causes the same thing, and that's a noxious substance such as potassium chloride injected into the system, because those are the two things that he considered at the beginning. So how did Dr. Evans rule out the noxious substance? How does one make a diagnosis of potassium chloride poisoning? Well, you really can't. It's very, very difficult, if not impossible, because post-mortem potassium concentrations are not reliable indicators of ante-mortem potassium levels because of a rapid rise in potassium levels after death. And this happens because all the cells are breaking down and potassium's getting released. And elevated potassium levels are usually then the norm at post-mortem. The only way to prove potassium overdose is through the collection and analysis of circumstantial evidence, the presence in intravenous equipment, syringes and vials and all that kind of stuff. Really not a medical, but more of a police investigation. So was that the reason that he was able to rule out, as he says, potassium overdose that he originally speculated may have happened? No, none of that happened for baby Ed. So Evans goes on, resuscitating patients or doctors is part of our bread and butter. Again, we've talked about this. Being a magical resuscitator doesn't guarantee anything. When CPR is unsuccessful, it adds to the confirmation of an air embolus diagnosis. Bullshit. That would mean that the over 2,000 cases we discussed yesterday in the American study of death following CPR were all due to air embolism. No, they weren't. So he carries on more storytelling, anecdotal stuff, which has no bearing on the proceedings that I can see. Dr. Evans relays one case of a baby who had died in Swansea from an air embolus. There we go, air embolus again. From what should have been regular surgical procedure. When recalling, it was absolutely awful and led to a criminal trial. So why is this man allowed to just wander off and talk about stuff to build up his case without it being actually directly related to the matter at hand? I don't know. He said he'd not been involved in that case, so he was unaware of any discoloration in that baby. But surely there has to be discoloration. It's being used as a hallmark, to quote the prosecutor in this case. He says he's never encountered such skin discoloration in a collapse in hands-on experience. There we go. That's something I am relieved and pleased about, actually. Again, I don't know what that means. Mr. Myers said the diagnosis is not an exclusion, ruling out alternatives until one explanation is left. And that is completely wrong, Mr. Myers. Dr. Evans said there is more to the case than that. He said his original conclusion was that he did not know about skin discoloration in baby Ed. He adds that if you discover additional information, that simply firms up your diagnosis. Dr. Evans states that air embolism cases are problematic because they are isolated case reports. Well, they're not. We have 5 or 6 of them in this instance, and systems are implemented in modern times so the conditions are not repeated. That is not a criticism, that is a compliment. Hence, there's very little new research. So Dr. Evans says there's very little new research into air embolism. Let's look at a piece of research that was available in 2015, and Dr. Evans could have used it when he was given evidence. It's called Prevalence of Systemic Air Embolism After Prolonged Cardiopulmonary Resuscitation in Newborns, a pilot study. So let's look at the abstract. Chest compressions during cardiopulmonary resuscitation, CPR, are the cornerstone of adult CPR protocols and are meant to restore circulation and improve outcomes. In newborns, however, the lung tissue is more fragile. Thus, the high intrathoracic pressures resulting from cardiac compressions may make the newborns more vulnerable for air embolisms. Okay, so that's the abstract. Now, the objectives. We studied the post-mortem prevalence of air embolism in neonates that had received CPR, and the methods were prospective cohort analysis of newborns receiving cardiac compressions during CPR. CPR was performed by trained staff in a tertiary hospital, so very high standard. Air embolisms were sought using computerized tomography, magnetic resonance imaging, and autopsy. So the results during the 6.5-year period between 2007 and 2014, 56 newborns received cardiac compression. So it's not a big number, but it's new research. Newborns were resuscitated following severe perinatal hypoxia or due to complications during NICU treatment. In 14 of the 56, circulation could not be restored. The mean CPR duration was 32 minutes, plus or minus 15 minutes. Post-mortem CT and MRI were performed in 9 cases, of whom 88.9, had air embolisms. I wonder would that make a difference to Dr. Evans' opinion now if he was aware of this paper, or would he say the numbers were too small? Unlike the Liam Tanthrow paper that had 50 cases in it, we've only got 56 in this one. In patients with CPR resulting in restored circulation, that was 42. No CT or MRI was performed for comparison because of radiation or hemodynamic stability worries. Cerebral ultrasound could not identify or exclude air embolism in the subgroup. So the conclusion of the paper: post-mortem CT after prolonged resuscitation showed a high prevalence of intravascular air embolism. Autopsy was not suited to detect air embolism. The clinical importance of air embolism and the lethal outcome needs further research. So there we have it, new research into air embolisms that Dr. Evans doesn't know about. So I just put vascular air embolism in neonates into the PubMed. That's the National Institute of Health library in the United States, the biggest medical library in the world. And I've come up with 1,172 papers. So I would think that that's a fair amount of research of where vascular air embolisms come from, how do we identify them, what's a reliable method of identifying them, but whether or not skin rashes or discolorations are characteristic of them, and all the other stuff and any other stuff we want to know about pulmonary vascular air embolism. And we're not being told anything new about it by Dr. Evans. He has a particular view of air embolism in neonates and preterm neonates, and I think he's probably the only one in medicine that has that view. So after the very little new research, quote, he carries on telling stories. He was tasked with investigating a clinical condition, not a crime. When he became aware of the Countess of Chester Hospital cases when tasked by the National Crime Agency, so he was not tasked by the National Crime Agency, he invited himself onto the task, and he is not investigating a clinical condition because he was given statements that were taken by the police. So that's a crime that he's investigating. He said the scenarios added to a constellation of worries about what happened between June 2015 and June 2016. Well, that's the one bit of a statement that I would absolutely agree with. He adds that in past cases, police brought him in and the conclusion was accidental. So the case was closed and no further police involvement again. What's that got to do with anything? So the police are involved in coroner's work? That's perfectly normal. He's asked about his state of mind when he approaches the case. And remember now, this is the man who told Rachel Aviv in the New Yorker that he imagined there was a noxious substance, and when that didn't pan out, we don't know how, he concluded that it was an air embolism. He says, my mind was obvious. Let's find a diagnosis. So this is in spite of the fact that a post-mortem was unable to find a diagnosis. Evans is now going to find a diagnosis. It was nothing to do with crime. Let's identify any specific collapse and see if I can explain it, when no one else could. There were occasions where I couldn't explain it, and I found something deeply suspicious. So there we have it. Because I couldn't explain it, because no one could explain it indeed, it was unascertained, it was therefore deeply suspicious. I find that deeply suspicious. There were incidents I found disturbing. There's plenty of incidents in the neonatal unit at the Countess of Chester Hospital that any doctor would find disturbing. He was asked to investigate 33 cases, with 2 insulin cases later. People were suspicious of 35 deaths, I presume, or 35 deaths of collapses. We don't really know in the Countess of Chester Hospital. And Letby was found guilty of a handful of them, really. So I wonder what happened in the other cases. And then he says, the name Lucy Letby meant nothing to me. I didn't notice that. Well, that's not true. He knew the consultant staff. He was reading reports that they had written, unless the reports wasn't given to him anonymously. I was the easiest physician and the most difficult. I was a blank sheet of paper. I had no idea and relied entirely on the evidence I could see from the clinical notes and apply my clinical experience after forming an opinion to the cause. So his clinical experience of our embolism is one case 20 something years ago, but that was sufficient for him to diagnose our embolism in this case. He said he asked for one case file for an idea of what he was dealing with. So he asked for one case file, I presume that's BBA, as I call it, index case, or the golden thread. Mr. Myers, was the phrase our embolus used at all? There we go, our embolus. Dr. Evans, no, as far as I was concerned, I was the first to use an our embolus. Well, that's not the case. Dr. Jairam used the term, or considered the term in 2015. I need to give the NCA, that's the National Crime Agency, a compliment. They never gave me a steer. They are good professional people. When Mr. Myers turns to the case of BBA, he asks that preterm babies such as BBA are prone to complications. Rather than answer the question in the positive, Evans says, that's why we have neonatal units. So I presume that means they are actually prone to complications. He adds that the care BBA received meant he had overcome the most difficult part of his life and was stable before deterioration again. Don't agree. Dr. Evans notes that Mr. Myers asks if BBA was perfectly satisfactory, in quotations, before the collapse. Dr. Evans does not want to engage in semantics, but adds that for a preterm baby in his position, BBA was satisfactory, really good. Also an emphasis on satisfactory, really good. A clinical note is presented to the court with several problems listed. Remember, this is the man who was described as an independent witness, but he clearly doesn't want to engage in the reality. Evans says, I would call them issues, not problems. This is what any competent junior doctor would list as issues present. We have to deal with the fact that he is preterm. He has breathing support. We need to establish feeds. There are concerns over suspected sepsis. That's Dr. Evans. Any doctor would write these things down. An X-ray review is present with the note respiratory distress syndrome type picture. Dr. Evans is asked about that comment. He says, I've seen the report. It's not too bad, actually. This is why we put babies on CPAP. A blood gas record showing a high number of lactate, so that's 2.6 outside the range up to 2, is shown. Dr. Evans explains that he wouldn't be particularly concerned about such a reading in the whole picture. As he says, 1 or 2 readings would be outside the normal range. And there were 3 readings given to the court, and 2 of them are outside the normal range. He said he would not interpret oxygen reading from a capillary sample from a heel prick. So there we go. He's not going to pay any attention to a capillary heel prick, but he's going to rely on oximetry. So just how accurate is that? The truth is that the only real accurate measurement of oxygen in a preterm unit is in an arterial line. That doesn't mean that you always have to use them, but they are the most accurate. They may not be any good for oxygen, and you have to go by other things. But what other things do they have? Sometimes you have to use what you've got, and they didn't really use what they had. We need to know as well who was reading these, because the evidence that we were given by the reporter seems to indicate that a doctor did not see the baby in the afternoon. Now, that may not be the case, but that's what was reported. And that is very, very concerning. And then Dr. Harkness came on at 5 o'clock, but he didn't actually establish the line until 8 o'clock. Now, these things would be more of an interest to me than downplaying the situation that BBA was in. So we'll carry on with this in the next episode.